bladder and urethra. You know where they lie? They lie near the perineum. Whenever there is a blunt abdominal injury or perineal injury or pelvic fracture, anything close to the pelvis in road traffic accidents, when a patient comes to you after a road traffic accident, we basically ignore these injuries. We focus morely on the bleeding, fractures, head injuries, and all. Most of the times, these bladder and urethra injuries are neglected injuries because we will be focusing on primary high traumatic situations like pneumothoraces, pericardial tamponates, brain injuries, head related, right? So instead of focusing on these, we focus on high trauma things. So why this is important for you, bladder and urethra? Most of the times, even if you do not focus on them, there's no worry. There is one disease which is a problematic, which is usually problematic, is intraperitoneal rupture of the bladder. Intraperitoneal rupture of the bladder, which has a picture of peritonitis and patient presents with shock. So this is only the severe one. Remaining all, just suprapubic catheterization is done. Suprapubic catheterization is done, and after the recovery of the patient, then we go for primary surgery for urethra, because later there is chances of development of urethral strictures or bladder strictures in these cases. But first and foremost, what is more important is, even if you ignore as a surgeon, there is no problem with these diseases. But you need to know whether what type of injury you see. When I talk about bladder, I am worried about whether it's intraperitoneal rupture or extraperitoneal rupture. This is my primary concern, whether the bladder is rupturing within the peritoneum, because if bladder contains urine, urine is infectious. Any material entering into the peritoneum, it might cause peritonitis and sepsis. So immediately I should drain it, right? And I should do surgical correction so that more urine will not enter into the peritoneum. But if the drainage is into the extraperitoneum, that is into the tissues and all, nothing wrong. If you remove the liquid, slowly the liquid goes out, and the remaining liquid, the body will absorb it and it will pass it again. So that way, extraperitoneal, there's nothing much to worry. But intraperitoneal, there are chances of peritonitis and sepsis because peritoneum is getting involved here. So this is our concern. Similarly, in the urethra, you have bulbar urethral injury and membranous urethral injury. Okay, this membranous urethral injury and extraperitoneal bladder injuries, they are like brother and sister. Okay, why brother and sister? I'll tell you. So this is membranous urethra. Just please observe here. This is the bladder, and this is the prostate. Inside the prostate, you have prostatic urethra. Prostatic urethra is commonly injured during instrumentation, not during any fracture or something. Only two, that is the bulbar urethra and the membranous urethra. We are only concerned with these two things. Look at the membranous urethra, how close it is to the base of the bladder. Okay, base of the bladder is commonly injured in extraperitoneal bladder, whereas the dome, apex, is more commonly injured in intraperitoneal, because the base of the bladder is extraperitoneal. The fluid extravasates into the extraperitoneum. Similarly, membranous urethral rupture also is in close relation to the bladder. So you see both these two injuries during the pelvic fracture because they are very close to the pelvis. So in pelvic fracture, you see two injuries. One, injury to the base of the bladder giving rise to extraperitoneal bladder injury. Similarly, injury to the membranous urethra. So urinary extravasation into the tissues is most common complaint here. This bulbar urethra is because of straddle injury. Bulbar urethra, see, straddle, any type of straddle injury. There are multiple scenarios. If you are exercising on a pole, suddenly if you fall onto the pole, there will be perineal injury, butterfly hematoma in the perineum. Then there will be bone, pubic symphysis and the straddle. They are both compressing this part of the, see this? There is a rod here. On top of the rod, if a person is falling, and there is a pubic symphysis, both are damaging the both are damaging the bulbar urethra. So these kind of injuries are known as straddle injuries. So whenever there is a situation of straddle injury is given, whenever there is a situation of straddle injury is given, we are looking in the terms of bulbar urethral rupture. Whenever there is a situation of RTA is given, road traffic accident, wherein you see pelvic fractures, we are looking in the terms of, in the pelvis, damage to the membranous urethra. So if you want to distinguish whether it's a bulbar urethral injury or membranous urethral injury, the clinical scenario, the accident scenario is very important. Straddle injuries, walking on a manhole. Suddenly, if this is the manhole, if a person is walking, okay, onto the manhole suddenly it's lifted up and there will be injury in the perineal region. So this kind of injury again produces rupture of the bulbar urethra. And as I told you, these two are brothers and sisters. That is, if you see a pelvic injury, you see membranous urethra rupture and also extraperitoneal rupture of the bladder. Now first we'll finish off bulbar urethral injury and membranous urethral injury, then we'll go back to the bladder injuries because we have started this discussion. Now when you see bulbar urethral injury, it's because of straddle injury near the peritoneum. So I could definitely see there is near the perineum, you will definitely see perineal bruises and hematomas in the perineal region, in the butterfly distribution. So you see butterfly hematomas in the perineum. Because membranous urethral rupture is because of the pelvic fracture in the pelvic region, pubic region. So there will be bruise in the pubic area and even scrotal area and penis area, not in the perineum. Second thing is, yes, there will be retention of urine in both the cases, because the urethra is for the passage of urine. Whenever there is injury either to the bulbar or to the membranous, urine will not form. There is retention of the urine in both these cases. So there is retention of the urine. So I cannot distinguish these two based on urinary retention. They are common. Now, extravasation of urine is also common in both the cases, because whenever there is an injury, the urine which is present here extravasates, and in both the situations the extravasation is extraperitoneal. But you know, there are a lot of structures near the bulbar urethra, lot of structures which limits the extension of the extraperitoneal extravasation of the urine. So the urine can only be present near the perineal region and into the scrotum. That's it. It cannot go up to the abdomen or top, like, or into the rectovesical pouch. So I can say that you cannot differentiate bulbar urethra from membranous urethra just based on extravasation of urine, but on the quantity of extravasation urine, definitely it will give you some guidance. That is, confined extravasation of urine is common with bulbar urethra, whereas more extensive extravasation of urine, almost similar to extraperitoneal rupture of bladder. Even in extraperitoneal rupture of bladder also, it can extravasate till the abdomen, okay, umbilicus. It can extend beyond the umbilicus. Similarly, it can go into the rectovesical pouch. So this can be seen. And next important thing is, in both the cases, you will see bleeding from urethral meatus. So blood will be present at the urethral meatus in both the cases, but there will not be any gross hematuria. So it's not gross hematuria what you see, but you will definitely see some blood spot or bleeding at the urethral meatus. One more differentiating feature from exam point of view, very important, is when you do digital rectal examination, prostate is normally situated in case of bulbar urethra, but because membranous urethra, see, very close to the prostate. If there is an injury here, if this is gone, the prostate will move up. I can say high riding prostate on digital examination is characteristic, pathognomic of membranous urethra, because they are in close proximity. If you know this picture, this anatomy, I think you can solve a lot of questions. If I ask you straight away, which urethral injury is associated with extraperitoneal rupture of the bladder? Membranous urethra, because it is close to the bladder. If I say in which urethral injury you will see high riding of the prostate, it is because of the membranous urethra, close proximity to the prostate. It is membranous urethra. So only and which urethral injury has extensive extravasation of the urine because bladder is also closed. So it is again the third one. So based on these 3 points, I had seen hundreds of MCQs in the last 20-30 years of medical PG entrance examination from the urology general. Please learn these 3 things. You can solve any question. Normally situated prostate is bulbar urethra. High riding prostate is membranous urethra. That's so. How will you treat also? On the treatment base also, I could see that they're asking questions. In both the things, stabilize the patient, but stabilization is more important because this is pelvic fracture injury, high trauma injury, road traffic injury. Many of the times we have to stabilize the patient and just pass a suprapubic catheter. We call it a suprapubic urinary diversion and forget about the patient. In very rare cases, if extravasation persists even after suprapubic tube, and if you need to drain the retropubic space which contains a lot of fluid, then we go for urethral or prostatic or bladder rupture, but many of the times we delay that surgical treatment. The same thing is true for bulbar urethra. The problem with bulbar urethra is more superficial injury, more superficial extravasation. There is a butterfly hematoma. Visually, it's more superficial. So pain will be there. Antibiotics should be given because risk of sepsis is high. Patient should be discouraged from passing the urine in this case, and bladder drainage is done. Again, suprapubic catheter passage is common for both. So the treatment of choice for urethral injury is suprapubic catheter. Here also we wait for at least 18 to 12 weeks and then we go for delayed anastomotic urethroplasty. Delayed anastomotic urethroplasty is done in these cases 8 to 12 weeks later. Most of the times we don't go for urethroplasty in membranous urethra because it is very high lying, it is tiny and surgeries are pretty complex. Even after doing surgery also the chances of stricture development. Okay, so that's why surgery is not an option, just conservative management is done. But surgery, delayed anastomotic urethroplasty is done 8 to 12 weeks later because strictures will form in this bulbar urethra which leads to urinary stasis. So we're done with the very important topic from today's discussion, that is urethral injury. Coming back to the bladder injury, simple, as I told you, bladder rupture can occur both extraperitoneal and intraperitoneal. Let's see how they occur. See, this is extraperitoneal, what you see here. Okay, there is a rupture of the bladder at the base. Okay, not dome is intraperitoneal. Because of the dome is ruptured, which is actually, most of the bladder is extraperitoneal except the dome part, which is intraperitoneal. That's why now it is going, urinary extravasation is going intraperitoneal. Okay, it is crossing the umbilicus here, extravasation, but here it is limited by the umbilicus here till the level of the umbilicus. It's above the level of the umbilicus, intraperitoneal. It's going inside. Okay, so there will be extensive extravasation but into the periphery, into the skin, but because this is in the peritoneum, the patient will have peritonitis. See, the same thing, extraperitoneal versus intraperitoneal. Just keep this image in the mind. Now let's try to differentiate with the help of a table. Most common is extraperitoneal, 80% of the cases. 20% of the cases is intraperitoneal. The diagnostic test of choice both for urethral and bladder injuries is retrograde cystography. And trauma situations are scenarios, accidental situations are important because in the MCQ they give you scenarios, right? So the blunt trauma, pelvic fracture or surgical damage. So what kind of surgeries will cause bladder injury at the base? During inguinal or femoral herniatomy or hysterectomy or rectal excision done in case of rectal carcinoma. These three surgeries, because they are in close, uterus is in close proximity to the bladder. Femoral or inguinal hernias are in close proximity to the bladder, and also rectum is in close proximity to the bladder. When you do surgeries on these parts, they might injure the bladder. So surgical damage and pelvic fracture are the common etiologies for extraperitoneal rupture of the membrane of the urinary bladder. Now intraperitoneal rupture is actually secondary to blow or fall on distended bladder. Okay, cycling injury while traveling through a cycle, or punch onto the bladder when it is full. Now, as I told you, intraperitoneal rupture, the patient will have sudden severe pain and syncope because it is intraperitoneal. Abdominal distensions will be there and there is no desire to micturate. Picture of peritonitis, that is guarding of the abdomen, rigidity of the abdomen will be there. And this patient, it's very important because as I told you, extraperitoneal rupture and membranous urethra, they're brother and sisters, and also bulbar urethra. In three of these conditions, you don't have to worry. Just put a subcutaneous catheter, that is drainage of the bladder, suprapubic catheterization for 10 days and antibiotics suffice. But it is very important to diagnose intraperitoneal rupture because it leads to shock. You need laparotomy and repair and bladder drainage, immediate requirement. So that's why we need to identify intraperitoneal rupture. Now let's solve the question from this topic. What's this? The question is, urinary bladder can be injured in all of the following operations except. As I told you, yes, it can be injured in inguinal and femoral hernia repair. It can be injured in extractomy. It can be injured in rectal excision, surgery for rectum. Not in the inguinal lymph node dissection. Okay, only in the herniatomy or hernia surgery, which is a bit deep. So chances of rupture, but not inguinal lymph node dissection, which is superficial surgery. It's as simple as that. So answer is option 4 here. So this will conclude our discussion on bladder injuries and urethral injuries. Very important.